for a couple of reasons. Now that we have a neurosurgical ICU, and over the last couple of years we've had more and more neurosurgical patients and medical neuro patients, subarachnoid hemorrhages and things like that, we're being exposed to more and more external ventricular drains on patients. Now we have more chronic patients who are here for things like trach and peg or IR procedures that are non-neurosurgical patients who have an external ventricular drain in them. And we really need to be confident in intraoperative and preoperative sort of management of this. And there's a kind of a case scenario or a case situation that we had that was kind of a safety event here. Was we had a patient who had a traumatic brain injury, young guy, and he'd been in the hospital for a while. He had had ICP issues, kind of sort of persisting. Obviously, if there's acute ICP elevations that we're managing acutely in the ICU, we're not going to be sending these patients to get elective surgical procedures done. But we had a patient who was scheduled for a trach and peg. I've already had 2 patients for trach and peg that have EVDs in, so this is a very common scenario. And so the patient had the EVD clamped, so to prevent CSF drainage during transport. But then when we got downstairs to the operating room, the drain was opened and the ICP was measured, and the ICP was high. So it was felt that CSF should drain in order to compensate for that CSF, and there was inadvertently probably an excess amount of CSF drained by the time the patient got back to the ICU. And so the patient developed hygroma, which is just a subdural CSF collection. And I don't think anything ultimately bad came out of that per se. I don't think it changed any of his events, but it's something that we want to avoid. It's obviously the complications related to external ventricular drains are fraught with disaster. So I thought it would be a good idea to bring an EVD kit here, bring our neurosurgery colleagues here to sort of talk about it. What probably are the most common reasons you put in EVDs in patients that come in?
So, for us, we're pretty aggressive as far as, kind of looking at forward. And, you get your subarachnoid hemorrhages, traumatic brain injuries. So we're looking at GCS. So and pretty much anyone with a GCS of 8 or 9 or less, we're probably going to put a intracranial pressure monitor. And that may be an EVD, that may be a Camino monitor. Obviously the Camino monitors are a little bit easier to manage. We're looking to trial, I don't know if you guys heard, there's a different, newer, updated version of the Camino. The old Camino was a fiber optic, and technically you're only supposed to keep that in the patient for 2 to 3 days, and you're at risk for drift after a few days. So they're not MRI compatible because they've got that bolt that you actually have to put into the patient's skull. So this one is...
Just to clarify, you're talking about an ICP monitor that's been put in the brain that is not used for CSF drainage?
That is not for CSF drainage. It's just for strict pressure monitoring. It's intraparenchymal. That one, the new one, we're going to do a trial. That one's an actual pressure monitor. It's not a fiber optic. You can bend it 90 degrees, you can tie it in a knot, and it's MRI compatible. That's one of the trials that's coming up, and that's one of the other intracranial pressure monitors that we place.
So we're going to be seeing different devices for these.
You will be. It's very similar to the Camino as far as placement. The monitor should be very similar, but just the added benefits of no drift, can keep the patient up to 30 days, MRI compatible.
But one of the things we see in the ICU, obviously now the neuro ICU is getting more subarachnoid hemorrhages, but we see a patient who comes in with a subarachnoid hemorrhage who initially is alert, arousable, things like that. You look at their CT scan, they have subarachnoid blood, maybe mild hydrocephalus or no hydrocephalus, and then over the next couple hours they become more lethargic and stuporous and drowsy, and that's really an indication for these guys that these guys used to put in an external ventricular drain, that there's some CSF or some obstruction developed.
Yeah, and especially if we see, usually with subarachnoid hemorrhages, there's associated intraventricular hemorrhage. And so that's when we start to worry, because we know that intraventricular hemorrhage is going to start to migrate down, and it's eventually going to cast the fourth ventricle, causing hydrocephalus. So that's when we kind of are proactive. If they're like a GCS, maybe 11 or 12, they've got extensive intraventricular hemorrhage, and we know they're going to start casting. They've got maybe a little bit of hydro already, and they're already casting the fourth ventricle. We know where that's going to head. So, we'll put in EVD at that point. Well, all the other ones, as you guys know, traumatic brain injuries, high-speed traumas, GCS is low. That's typically when we'll put an EVD in. The reason why we put that in is, with the GCS low, we want to just rule out intracranial pressure, intracranial hypertension.
Is there any indication in an intraoperative procedure for a craniotomy for some reason that a patient does not have an EVD in, and you would put a new EVD in the OR for something? Or have you seen that here?
Like, as far as like exchange or?
Yeah, I mean, just like you would put something in.
Sometimes when the trauma comes in and we rush them straight to the OR, we'll place them in. So if we do a hemicraniectomy, we'll try to do an EVD through the craniectomy sites, or we'll go contralateral and put one just kind of fresh.
The other thing I haven't even mentioned is also lumbar drains is something that we see every once in a while with a patient who has diagnosing pseudotumor cerebri or normal pressure hydrocephalus. We also use them occasionally in a thoracolumbar aneurysm resections. And that's a similar, I think it's the exact same setup.
The nice thing about this set is that you can use this for both lumbar drains and externoventricular drainage. There is a...
So basically, so you decided to put an EVD in, and this is the kit that you guys will be exposed to. I think this is a newer kit that they have up there.
Yeah, so I've used this in the past. I used this at Central DuPage Hospital. We're actually using that at Good Sam initially. But the nurses really didn't like it, and the guys were typically using the Medtronic system. Okay. So we had switched the Medtronic system. When we came here, we switched everyone to the Medtronic system, and then I think literally like a few weeks later, the system switched us back to Integra.
Okay. So essentially, the setup is it comes on this plastic kit here. You can go ahead and just open it up like you normally set up. So one side obviously has a connection. You have a separate tube that you put in the patient, and then that connects to that.
Correct. So we'll flush this with preservative-free normal saline. You can do this aseptic, but the nurses like to teach them to do it sterile.
Obviously, this is going to be all set up for you. It's just familiar
Correct.
with the tubing and the placement. We can all pass this around, take a look at it.
Yeah,
so
so this is our newer set. The other set, and I'm sure you guys have seen, the stopcock was like 6 inches away from the patient. So this is a longer extension tubing from the patient to the stopcock. Before it was like right here. So what happened is you're at risk for pressure sores with the patient just kind of laying on it. Even just kind of dangling there, you don't used to worry about that. So this is nicer because you get more freedom to the patient. So this will go to the patient. This will all be flushed. The transducer doesn't come with it, so there is a separate transducer that we that will place on here, just like your typical A-line PA.
I think the big difference is that the transducers that they use are a flushless system. It just goes directly on it.
Yeah, so again, they're changing. There was I forgot which company it was that we were currently using, but it had the transducer, there was a 3-way stopcock, and then there was that pinch clamp system to flush it. They're switching it over again, so I think Edward Sciences is the new preferred vendor. Yeah. So they're swapping the single transducers to a flushless system. I think you guys will get the blue pull tab.
I think most of these are already going to be set up with the Edwards flushless system that you have. We're not going to be setting up a new. I went and talked to Allie downstairs, our anesthesia. She says they don't have the flushless system set up. So they're already going to be for us. They're already going to be set up. The big thing is you don't want to have that hooked up and then be flushing a big amount inadvertently into the interventricular space where the
right. You can flush distally all you want if something to happen if you did something accidentally, but obviously proximally to the patient you just want to be careful. The other thing I want to say about that flushless system, without that safety valve system, we just want to make sure it's clamped, because if it's not clamped, you know, towards this way, away from the transducer, then obviously it's just going to continue to drain, and you have that risk of, again, just overdraining CSF. So we just want to make sure that's clamped. It should come with a occlusive cap like this. So that's another safety valve, but just make sure that's clamped right there also.
So this basically, so you have the setup of this, I can take this end. So like, this is in the patient here.
Correct.
And so the big thing is just pre-operative and intraoperative management of these things. And so one of the big things to avoid excessive drainage, and most of us already know this, is usually any kind of change of position or any movement in order to avoid drainage, we clamp or turn the stopcock off to the patient. And so typically we're using this. So you'll have on this one, it'll be the pressure transducers coming over here. So you have 3 different directions to go. So if you have it off to the transducer, you cannot measure ICP, but the CSF can go through here and drain in this collection bucket over here. If you have it off to the collection, it's going to go through here to the patient to the transducer. And so that's when you can measure ICP. I don't know if you can, I don't think you can, well, maybe if you do this, you can simultaneously measure it.
You can.
But
It's not going to be accurate because
Yeah.
you're obviously going to be open to air, but you can at least trend it, and the nurses in the ICU like to do that. We don't like to do that, but they like to see any trend, so that way, even though it's not an accurate reading, they'll see a trend. If it starts trending up, then they'll actually turn it off and get a more accurate reading. So they just use it for trending and for drainage.
So the big thing is the CSF will collect in here, and this is how the nurses can tell, you know, this is 510, I don't know if you can see this, but the volume of CSF drain will be in here. And I don't know if the nurses, I think they typically like to drain in this collection bag prior to operative procedures, so we know how much is coming out. So this is the big thing. Now, there's also a 3-way stopcock here, which is preventing stuff draining from this collection tube to the drainage bag. This is, you know, not really measured. This is where you take cultures or CSF samples, right?
Do that.
Yeah,
correct.
So this is usually off to this to prevent drainage. And so essentially when we clamp, I clamp it right here. So I turn, and you could also use this, you could also use this too, but if you kind of use one thing, you're gonna, you know, if you do the same thing every time, you're gonna not make an error. So if you turn this off to the patient, and this is like when you're about to transfer the patient down to the unit, I tend to do it there. The other thing is it's just a discussion with the ICU nurses. Have there been ICP issues? You know, how have the ICPs been? The last patient I had, the ICPs were normal. They've been, you know, 8 to 10. They're not draining a whole lot. It was not a big deal. Obviously, they're stable for trach and peg. But there are some patients that ICPs are more of an issue. And so that then gets you into a kind of different clinical situation when you're in the operating room. And so this is basically clamped off to the patient. Now, when you get in the operating room, you typically you don't want to just leave these things clamped for hours at a time, right? I mean, you know, 15, 20 minutes to transport to a procedure is fine, but once you get in the operating room, it's not a good idea to leave these clamped for most patients, I think. I mean, I know most patients, some of these patients are weaning these EVDs and you clamp it. It's not the end of the world.
By the time they get a trach and peg, I mean, they're probably more stable.
Right.
You know, ideally, you know, if they're going for a trach and peg, you can probably keep it clamped for an hour or so, but I mean, ideally, if you do keep it clamped, you would probably just continuously just transduce the ICPs just to kind of keep an eye on it. Normal range for an adult, 8 to 12, but typically our guideline is anything over 20. We just want to reevaluate the patient. So anything as far as ICPs over 20, anything over 20 for drainage, you know, so if it's drainage for more than 20 cc's for drainage, we usually just clamp it for an hour. But again, it's kind of per patient. For you guys, you probably won't see that.
Yeah, I'll get back to you.
As far as,
on top of me, I was a post-call guy overnight, so.
High ICPs, because like I said, they're
Who
more
calls
stable,
who's day call?
ideally. If they're having ICP
All right,
issues.
hold on, let me hand you to the day call person. Hold on. Heart station.
If they're
So
having
it's in the
ICP
cold
issues, then, you know, obviously they're most likely not going to go down to the OR. So we're just going to wait for them to be a little more stable.
Jesse, what'd you say the maximum per hour drainage is?
Typically, we go by 20 Cs per
20
hour.
cents out.
Yeah, so it all depends on ICP, so if ICPs, thanks, Connor. If ICPs are high, we'll actually drain CSF just to see if we can relieve some of that pressure. So if they're already at 20, but their ICPs sustained for an hour at 25, then maybe we'll drain a little bit more.
Jesse, so what we often see or can see is the patient's ICPs are stable for a few days, so they say, oh, they're okay for a trach and peg, and they're really quite on the borderline. Now you transfer them, now they start doing surgery, and they do
Training up.
plus then they do a pneumoperitoneum to do a laparoscopic G-tube. Now the ICP's 30.
And they're totally flat. Where
And they're
it's up to
flat,
30 degrees.
and they're in pain, and so all of a sudden now we do have a high ICP, and then, so we open it, we drain 20 cc's, ICP still 30 or 40, we shut it off, we don't drain anymore. Should we have a hard cutoff?
Yeah, I mean, I wouldn't drain. Typically, I usually drain maybe 5 to 10 cc's and see how they react to that. I wouldn't go straight to 20. I just kind of go incremental.
Mhm.
But yeah, I would. First thing, just make sure their head is straight. They don't have anything, blocking their jugular drainage. So that way we can make sure that ICPs can have any relief with that. It's just simple, just mechanics and physics.
I guess the big question is, should we stop the surgery if that's
I mean,
occurring?
if you can at least increase the head of the bed, that may help. But yeah, it all depends on how much longer they're going to be. If it's a beginning case, we may have to think about
Yeah.
boarding.
I mean, that was the situation that we had. Was that
Mhm.
it was the ICPs were high. Now, just the other thing too. Did you
it also
talk about
depends
the
if they have
leveling?
hydrocephalus. If they're just GCS and they don't have hydrocephalus, then you're really not going to be able to drain much
Right.
CSF. And
Did
it's
you
gonna be
talk
one of
about
those
this
things.
leveling?
I did not.
Okay. So this once you get into the operating room, you want to have this level to the patient. So this kit has a leveling bubble, like your typical level here, that's snapped into there, and where you typically do this at the external auditory meatus or something like that.
Mhm.
So this little ring right there can go to the patient's ear when they're lying flat, and then this thing is supposed to be level. This little bubble here, just like a regular level, and that kind of levels to the obviously if you're too high or too low, it's not going to drain properly, or it's going to excessively drain. So that's kind of how we set it up. There's these little clamps right here on the back, which can a lot of times they'll just have these set in the bed, and so we can
Yes.
you squeeze these little
So
tabs.
there's kind of belts and suspenders. So there's the clamp that goes around the IV pole, and then there's the strap that goes around also.
Right, so that you put it on the pole. You don't want to just have this lying in their bed, I don't think.
Yeah. So if this is nice because the old Becker system, if you laid it flat and the air valve got wet, you would have to change the whole system. But if you did lay it flat and you see, it's kind of inverted, if this gets wet, you don't have to change the whole system. It's fine. So don't worry about that.
What's the point of all the markings on there? Like, when do you raise and lower that thing?
So typically, if they have hydro, or when we place these, we typically leave them at 15. So there's 2 scales here. There's millimeters of mercury and centimeters of water. We always go by centimeters of water. We typically start out, I would say, majority of the time at 15. Sometimes if they're in real bad hydro, then we'll start them out at 10 centimeters of water. So that's kind of our starting point. And then when we start challenging the EVD, then we'll go from 15 to 20, 20 to 25, and then clamp.
So what that means is if they have a CSF intracranial pressure above
Gradient
that,
above
it's
that.
gonna drain, it's gonna spill over. So if they're below that, it's not gonna drain. If it's above
So
that.
just think of it as a relief valve. So anything above 15 centimeters of water, just imagine our back in high school, our pressure gradient is greater than 15 centimeters of water. So anything above that intracranial pressure is going to dump CSF.
And so clamping it is the ultimate end stage of challenging the EVD to see how the patient's tolerating it. So that's closing it. So the pressure is, raising that up and up means that it takes a higher CSF or intracranial pressure to drain. So if you're up there and your EVD set at 10 and they're still draining, they have elevated ICPs.
Right.
If they're at 10 and they're not draining much, the chances are pretty much they're probably okay.
Yeah, so again, this is a little bit more tricky as far as the scale, but again, it's always centimeters of water, and it's this little red tab here.
And the transducer is always at the same spot on that thing?
Correct.
Okay.
It's here.
And you attach this to like a pole when you're
An IV pole, yes. Yeah, and then like kind of was saying, just measure to the external auditory canal, because that's the level of the third ventricle, and so that's typically where we measure it. And then
Yeah.
you can adjust the bed. You can either adjust this on the IV pole, or if you got a bunch of pumps on there, you can, if you can, just adjust the height of the bed.
So if you're doing a case and let's say you're putting a peg and then putting the scope in and it can cough and you see that go up, we just wait till we have an equilibrium, or just don't think about that?
Yeah, obviously you're just gonna see what caused that. Anything sustained is when you wanna be a little more vigilant on, what's causing it. If you need to call us, if you're not, certain, or if you're worried, then we can come in and take a look at it, and that won't be a problem. But anything, obviously, all of us, that happens with all of us. We just don't know because we're not walking around with DVDs. So, you guys know. If you see a spike and they're coughing, or there's something that's kind of stimulating them, then you'll know.
That's why the first thing I give all the trays is a big dose of muscle relaxant.
Wait, you mentioned
You do,
earlier, but
you
what's
do.
the risk of overdraining?
So, like the RD that was filed with the overdrainage. So you can get subdural hematomas from it, from overdraining.
So just a negative pressure causes pressure on the bridging veins, and it can pull, actually cause a problem. So there is problems, and also inadvertently flushing something through there can be a problem. Something gets disconnected, you can get contamination. Obviously, this needs to be a very sterile thing. So that's why I just wanted to make sure we're all confident with this. So. Let's say we have a problem with this and we're worried about ICPs. How do we get a hold of you guys?
So our BRIC number is 21-2052. That's 24/7. We'll come down if you guys are having an issue. We'll just come down and.
So there's an in-house neurosurgery PA 24 hours a day at that number, 2052.
2052?
2052.
2052.
And so, pretty much you guys are, there's all the new patients that are coming in, the medical patients have you guys, AMG neurosurgery on consult. It's only like the elective cranies and stuff that the groups that you
Yeah,
guys
they
don't
won't have
cover.
an EVD.
So that's always it. 2052 is the number to get a hold of somebody. They'll answer the phone, and you'll be able to, hopefully, unless you're busy.
Yeah.
But at least they'll be able to give you some guidance. on
Right, so we
manipulation.
troubleshoot at the beginning and try to guide you guys, and then hopefully we'll be able to just pop in and see what's going on.
So the bottom line is when you deal with a patient with an EVD, you need to have a thorough discussion with the bedside nurse, talking about what the ICPs have they been stable, and you can refresh yourself by asking the ICU nurse to make sure that you have this clamped before transportation, you have it clamped the correct way. And then, they know the best, they're using these things all the time, so I always just, double check that it's the right transducers, the correct transducers clamped the correct way, because just one turn of the stopcock and you have it the wrong way and you're draining excessively. So, and then also just to make sure that if there's CSF already in here, when you go down, if you're going to open it when you get down there, just make sure you have note of this where they drain it before you go down there, so you can have an accurate measure of the CSF that's been collected. Otherwise, otherwise you don't know if that was already in there or if it's
What's your starting point.
What's your starting point. So, 10 cc's, 20 cc's can make a huge difference in these patients, and it's a pretty subtle difference here. So, does anybody have any more questions? I think that's basically.
Yeah, I think that covers, yeah, the majority of what you guys will run into.
So I stole this from the surgical ICU, and so we can play with it, and you could just see to make sure you know all the way the stopcocks go, and the two different important stopcocks here. This one pretty much you won't have to mess with that one. The nurses will challenge this, so this should always be off to prevent drainage here, so it collects without draining.
I think the important thing is always to make sure you clamp it during transport.
Yeah,
because that's when the thing can go up or down.
Yeah, and if you're moving the bed up or down,
right,
any change in the patient's position can cause CSF drainage. So yeah, that's a big thing. Just make sure you always know where the tube is, and these things often get pulled and stuff when I hate transporting patients with an EVD just because it seems dangerous, and that's why I wish we would do bedside pegs, but bedside tracher pegs, but that's a political issue right here. So we can't steal the laparoscopic G-tube from these guys.
It's so stupid.
Yeah, I mean, really, laparoscopic
Connor,
G-tube.
if you're level, is there risk of overdraining? If you're out, if you're level and they're bleeding and there's a lot of blood, I mean, if you're.
I mean, if you're leveled and you have it open to the patient and they have elevated ICP,
it'll shoot out of that.
I mean, yeah, or if this is, or if the patient, this is way below the patient, and I believe it's if this is below the patient,
Yes.
it's going to excessively drain too.
But if
So,
you're level.
yeah, no, I mean if they're level and there's intraoperative changes, yeah, I mean that's what that's the big concern is that if you have it open, that you're going to drain too much. So you got to make sure that it's a good idea to measure this. The EVD that I had was still the old clip, and we didn't have the old it was that like telephone jack thing.
Yeah.
So I couldn't measure ICP during the case, so I had to just assume that it was okay. And I just opened it for 5 minutes to make sure I knew that not a lot was drainage, and then clamped it again, and opened it a little bit, and then clamped it again. So it was fine, but yeah, so that's why so I always bring that, it's a good idea to bring the transducer down, hook it up, and get your ICP waveform so you know where you are during the case. So.
Does the transducer come off of this thing?
Yeah, so this doesn't have a transducer hooked up to it, but they should have, and the big thing is that it's a transducer that looks like our transducer, but it's just connected to a cable. So it's like it has that phone jack cable hanging off here, and it's got those connectors, the transducer monitor here, but there's not a pressure bag connected to it, because you don't want to be able to flush this inadvertently.
Yeah,
So
it's just a single transducer.
Yeah.
Will that go into our monitor or it has its own?
yeah,
It's the same transducer.
yeah, it's
as your
Edwards,
A-lines,
the Edwards thing, so it should all be the same. So
It is different to zero these than an A-line though, so I don't know if you wanna go over how to zero them.
It's similar. You're just opening
Well,
up to air.
Yeah, but you have to lower it and have it all at zero, technically.
Technically, but
I mean, if you're just zeroing the transducer, it just is to atmospheric pressure. So like you have this off to the patient, whether you're here or here.
No, but what I'm saying, so usually what I do is I bring the patient down, I get them in position, I put it level with the patient's ear. Then whatever it was set at, the height, if it's 15, 10, whatever it was upstairs, you clamp to the patient, you lower that down to zero, hit zero on your monitor, and then raise it back up before you open it.
Do you guys do that to zero? Do you guys put it down here?
I don't. But
Because it's technically
the
zero
nurse-
to the pressure
the
in
nurses
the
do.
system, not atmospheric pressure, you don't take the cap
So
off.
if the transducer's here and you're zeroing it to atmospheric
Right,
pressure here, then yes.
Yeah.
But if you have that three-way stopcock here and you're zeroing it to that stopcock here, then no, you don't have to.
But aren't you not supposed to take the cap off, because otherwise
If
it's
you
not
do,
going to.
if you do take the cap off, you have to put a new one in. So
Right,
that's
because
how we.
it's a sterility thing.
Correct. I mean, if you do aseptic technique, it's probably fine, but typically our rule of thumb is, yeah, you take a cap off, you put a new one on there.
Can you go over that again?
A new
How are we
cap.
supposed to, once you get the patient there, how are you supposed to zero?
So the easiest way probably is the way you explained it. So take note of where it was leveled at. So if it was at 15 centimeters of water, just make sure you remember just 15. There's a pinch clamp here. So you bring this down to 0 centimeters of water. The transducer will be here. So just make sure it's off to the patient and the transducer is going towards the burette, the drip chamber. Because that's where this is your atmospheric pressure. This is where you're zeroing it to air. So as soon as you bring it down to 0, you have the transducer.
So you're gonna be off to this?
Off to the patient.
Yeah.
Yeah, off to the patient. Yeah, so off to the patient, and then you can zero it. Once you get your 0, then you can bring it back up to 15.
So you don't have to open this up?
No.
You really shouldn't,
Yeah.
because
Yeah.
that's
No, I know.
when
I
you
do,
get
yeah.
infections.
Right.
So that's why I like to do
Don't
it that
even
way,
take
because
off
you don't
that
even have
cap.
to take the cap off.
Okay.
No, the easiest way is like you said.
Yeah.
The way we do it is the transducer's here and there's another 3-way stop back here. We zero to that when we put it in, only because we have we're putting new
But they're
caps on
also
there anyways.
zero
Right.
already.
Yeah, and we're putting the new caps on there anyways. So that's the way we do it that way. But yeah, you're right.
Yeah, so that's actually a very important point.
So, but
to
if this,
bring up.
but if the system's been zeroed upstairs, we don't need to redo it, right?
Yeah, I haven't been
No, I never
rezeroing, I've
do
just been
either.
plugging it in.
Well, when you transfer and you hook up to our monitor, you have to zero it.
Yeah, technically you
Probably
probably
should.
should. It's just like an A-line.
Right.
Yeah,
When
it
you
is,
A-line,
just like you
A-line.
disconnect it
If
anyway.
it's a new monitor,
I mean, you'll still get the value.
If you bring an A-line into the room, don't you reset?
yeah.
Yeah, I mean, we usually do for it, but yeah.
These monitors that come with it.
Yeah, good point.
So,
They have ICP, reciprocal,
Oh, yeah.
so the devices hook up to our Edwards monitors now.
I mean, usually it's like whatever you hook up is, you get the same value, so.
Yeah.
All right,
It's probably not much.
that's an important point, so.
Couple more quick announcements, we're still in,
All right, thanks, Jesse.
DMV,
Thanks for
auditing mode, so you gotta get your pre-op done into the EMR
It's just
before the
doing
patient
our
gets to the
corporate
room.
announcements, so if you wanna
And
take off.
fill out your paper pre-ops completely, because those are being checked for completeness, and we're trying to hit 90% compliance on that.
So we should drop that down.
And-
This is about it.
That's it.
So Jesse's gonna stick around if you guys wanna come up here.